YouTube folks, this is your $1 million day. You should go buy a lottery ticket because we forgot to hit record. Well, I forgot to hit record for the last 6 minutes, so you get to jump right in. But before we jump right in, I'd love to reintroduce you to our case presenter, and I will summarize what we've learned. Eugene is from the best country in West Africa, Ghana. It's 1 p.m. there, and we are getting to know him a little bit better. So, Eugene, can you tell us where along your medical journey you are?
Yeah, absolutely. So I got my license to practice in Ghana about 3 years ago. So I've been in clinical practice for about 2 years and then 1 year of research. So that's what I'm currently doing. But my research will end in June, and then
I
I'll
see.
go back to clinical practice. So yeah, that's where I am at the moment.
Incredible. What are your hopes and dreams in medicine? What would be a dream come true for you in 5, 10 years from now?
Oh, well, actually applied to residency this year, but unfortunately I didn't match. So that's actually my biggest dream to start residency in the US.
Understood. You have a lot of people in the space have that shared dream with you, and it was not quite matching, but coming to the U.S. for education for me was also a big dream, and I'm very lucky that it happened. And I think part of the space is also trying to make it happen for everybody who is working hard like you. But without further ado, why don't we jump into your case?
Yeah. Okay, so we'll start with the first aliquot. A 35-year-old woman within 2 weeks postpartum presented to our facility with fever, altered mental state, and generalized muscle stiffness. And I'll pause here.
Yeah, and I can see why you were nervous. What an explosive start. Yeah. What thoughts are crossing your mind?
Yeah, okay. Just to verbalize, the first part of this entire aliquot that just jumps out to me is the fact that this patient is 2 weeks postpartum. So that automatically completely shifts my differential because now, had I not heard that, we come across ultramental side stiffness quite frequently, but the postpartum picture definitely shifts everything that I'm thinking of. I will be very honest and say I don't have a lot of experience caring for postpartum patients, so this will be a very important learning opportunity. But here's my initial approach. Anytime there is a postpartum patient and they're having these fevers and signs of what look like inflammation, my first thought is there a component of infection? Is there either retained components of placenta? Did something happen with the actual labor process? I think it might be helpful, and I'm sure we'll get to this later in the aliquot, but to figure out was was the pregnancy successful? Was the baby delivered? What actually happened during that course? I think that'll be very important. I think it'll also be important to know at what week gestation this happened. A lot of details right now that I think we'll get more clarity on as we go further down. But my initial thoughts are number one, is this an infectious cause? Number two, could this be an autoimmune or an auto-inflammatory process? That to me is a little bit lower on the differential because of the time course of this, but it's still something I'm thinking about. And then, the last thing and like the must not miss things are for anybody who comes in with fevers, altered mental status, and what sounds like stiffness. I just want to make sure I'm not missing like a meningitis encephalitis picture. And so, of course, as I talk to the patient, as we get a physical exam, I think that'll also kind of clarify what's happening. But this is a lot to delve into. So this is a great one-liner, Eugene. Robbie, what are your thoughts? What are
Yeah.
you?
I think you're framing it very, very well and really latching on to the key details that you want. And I agree with you. I think the no misdiagnosis is meningoencephalitis here. And I think the only thing I'm struck by, Dan, is just how diffuse this process is. This person seems to be hurting and stiff in every single muscle and is confused. And so it's not hard to imagine that when we cast a glance at this patient as we get closer to examining her, but even just from the room, we're probably going to have to explain diseases from head to toe. Essentially, like her feet are stiff and her head is confused. And the fact that she's been taken over by something so widespread is very, very intriguing. And the question will be to try to figure out, is this truly a systemic disease involving head to toe? Or is there a focus of asymmetry that is launching a cascade affecting the whole body? So, for example, just to hammer it home, if we find that the patient has right upper quadrant tenderness, that foci of asymmetry may say, okay, I think the disease is living here, and is ravaging the rest of the body because of its severity, not because it's everywhere. So cholangitis, for example, would cause right upper quadrant pain and the patient to be confused and not feel great. And so right now I'm going to try to figure out, is this truly a diffuse symmetric process affecting head to toe? Or is there a sneaky place where this disease is hiding that I need to target? And I think careful attention on the history is key, but I agree with you. Who she is going to be very important in terms of pregnancy complications, and the no misdiagnosis here is meningoencephalitis. I love it. All right, Eugene, Mike to you, my friend.
Those are very great thoughts. So I would point out that this patient is actually coming from a rural setting. So before we saw with these symptoms, it was seen in a rural facility with low resources. So the history was actually obtained from her husband as she was disoriented. She was first seen in a low resource health center in a rural setting before being referred to a facility. She had a cesarean section at 40 weeks and 6 days gestation and delivered a male child. 3 days after delivery, she complained of headache, malaise, and eye pain, which slightly improved on over-the-counter analgesics. A few days afterwards, her husband noted behavioral changes. She began drinking excessive amounts of water, which was unusual for her, then went on to an absolute refusal of water. Her husband described it as though she was afraid of the water. She also refused food and sometimes became selectively mute. These symptoms occurred intermittently for a couple of days, after which she was noted to appear restless and agitated, followed by physical aggression towards her relatives and even her baby. She was then taken to the nearby health center, and she remained there under their care for 48 hours before being transferred to our facility. Her referral was prompted by the worsening muscle rigidity, continuous spiking fevers, and 3 episodes of tonic-clonic seizures, which were aborted there with medications. On arrival to our facility, she was confused, unable to communicate effectively, and had generalized muscle rigidity. She was also sweating profusely, and I'll stop there for us to continue the discussion.
Wow. Wow. That is an incredible sequence of events. So just so that I can mentally break down what's happened. So this patient at her baseline level of function is able to communicate, is able to interact normally, has a C-section. After that C-section has a cascading sequence of events that ultimately progresses from headaches and eye pain to then fear of water, fear of food, progressing to seizures, and ultimately almost complete inability to communicate. And this has happened, if I understand it, over the course of a few days. So we are seeing a rather dramatic progression of altered mental status. So, just the fact that I'm seeing this sequence of events along with the muscle stiffness and AMS, now I'm really pushing neurologic etiologies kind of to the forefront of my differential. Specifically within neurologic etiologies, you said the words afraid of water. So I have to say my gut response is this a rabies encephalitis picture? Is that what's going on? I again, to be transparent, I have never seen a rabies encephalitis. I've only read about it, but that would be the biggest thing that I am worried about. And I think from my understanding of how encephalitic pictures present classically, this does fit with that time frame of you initially have a confused phenotype that progresses into true just neurologic dysfunction. The biggest thing that I worry about is actually our treatment course for this patient, because my understanding is once you progress to this point, if this really is rabies, our treatment options are very limited. So I already I'm kind of raising the red alert. If I saw this patient in the hospital, of course, I'd be doing all of the diagnostic workup, but I would also probably start a goals of care conversation with family members because I would just be a little worried as to what our end goal is. So anyway, on my differential right now is still encephalitis, favoring rabies, but other things it could be are, of course, any viral encephalitis, like an HSV. You also mentioned in your stem that I think the patient was having some not fear, but becoming agitated towards her child, I think. Much lower on my differential, but I also just want to make sure I'm not missing a postpartum psychosis. again, it wouldn't fit with the other infectious symptoms, but just something else I'm thinking about. Yeah, those are kind of my my initial thoughts. What are your thoughts, Robbie?
Oh my gosh, I think the way you have a knack and a skill to articulate very clearly for those following your thinking um, how important it is that you understand the sequence of events. And I think how you broke down the fact that you emphasized she was healthy, and then this happened, and this happened, and this happened. And the conclusions you're coming to are outstanding. And I really have nothing left to add, but to reinforce that you should have a reflex to think that when a patient has hydrophobia or aerophobia, to really prioritize rabies, not because it is common or probable, but because it is absolutely deadly. And the question that I'm wondering is this hydrophobia or aerophobia because of the patient having essentially a hyperspastic and reflexive gag reflex that essentially has patients gag at the slightest contact with any stimulant of their oropharynx? Or is this a behavioral perturbation where the patient, because of not hyperreflexia in their gag reflex, but because of a behavioral issue, is having an abnormal relationship with her child, an abnormal relationship with ingestions. And so I think that's the question that I'm trying to tease out. And I think you would have to be there to observe subtle things about the patient, about whether um, there is, yeah, I don't know. I've never been in this situation, but what I'd be trying to do is push myself to try to figure out, is this person just avoiding water, food, whatnot, as a part of a generalized behavior perturbation, or a selective issue targeting those things because they make her gag? Um, but I don't know if I don't have any actual skill to do that, but that's what I would be wondering. And the reason I'm open to the latter, the behavioral issue, is because there's a lot of other abnormal behaviors happening here. But if we were to ask ourselves, to layer on to the question that was asked in the first alquad, is there focality in this disease? And I think the answer is absolutely yes. Yusuf and I had a case like this where we shared the conversation that it would be simple to say this person has a diffuse cortical encephalopathy, the most common form of AMS, where a patient has hyponatremia or a UTI and they just kind of get confused. But this is not that. This patient has disease in her basal ganglia. And essentially, the localization of the syndrome is a basal ganglia syndrome, as evidenced by two things that are occurring synchronously: a movement disorder, namely her stiffness, which we'll be able to confirm on exam, but certainly seems suspicious, and then behavioral abnormalities that reflect a change in personality and a change in relationship with ingestion and water. So this is a classic basal ganglia disease. Um, and if you stretch out the time course and you have somebody over 7 or 10 years developing rigidity in their muscles and behavior abnormalities, this would be a Parkinson's spectrum disease, and we would have no problem rendering that diagnosis. I think it's just a little bit unfamiliar because of the relative acuity of it. But if I stretched out the story over 15 years, I think many people would find it plausible that this person has progressive supranuclear palsy or multiple systems atrophy or atypical Parkinson version, and so acute basal ganglia diseases. And the evidence for that: selectively mute, relationship with her daughter, stiff muscles, all those are very, very powerful. So I think we are now solving a subacute, progressive, febrile basal ganglia disease. And I think the question is, how do we make progress? And I think you're right that we have to not overlook simple clues in the medical history that might be pre-existing clues. Um, but I think careful attention to other localizations on the neuroexam. But then I think the question will be, is this image positive or image negative basal ganglia disease? But right there with you. I think we have a localization. We have a no misdiagnosis, and I think the key will be, let's take a glance at the background, make sure there are no other prominent clues. Let's make sure there isn't another localization on the neuroexam. And then I think the key question is, do we see on imaging, or is this process a subradiological one? All right, Eugene, mic to you, my friend.
Yeah, those are very great thoughts. So we were right there with you on thoughts, and so we went on further to find out more information from the husband. And we asked for animal exposure, and he indicated there was no animal exposure according to him, and then also no recent travels. And then the past medical history, she had a history of mental health disorder, diagnosed about 10 years ago. And he couldn't specify the exact mental health disorder. And she was treated for 2 years before she stopped her medications because she felt she was better. There was no known history of previous seizures or seizure disorder or other chronic illness. Her pregnancy and delivery had no significant complications. And for the cesarean section, she had a spinal epidural anesthesia. On a drug history, she came with a referral sheet. So it indicated that she had received a single dose of nifedipine for a high blood pressure reading. The reading was 178, 140 and but the BPs were normal during pregnancy. She also received antibiotics for suspicion of meningitis and postpartum sepsis. However, they have not made a clear diagnosis because of their low resources. And she was also sedated and seizures were aborted with lorazepam. She's not on any long-term medications, and she's allergic to ceftriaxone, ceftriaxone, and ciprofloxacin. I will stop here and then listen to the discussions.
This is unreal. Yeah, Dan, what are you thinking?
Yeah, so the past medical history involving the mental health disorder for 10 years, so I guess my first thought is this signal or is this noise? And how am I incorporating that into the patient's current story? You know, there are so many details that we mentioned in the HPI that makes me lean away from this being a primary psychiatric condition. And I think the point that Rabih made about basal ganglia involvement, especially with the movement disorder and the behavioral changes, I think to me that it still puts me in the neurologic etiology bucket. Now, could that be contributing? Perhaps, but I still don't think that this is going to that mental health disorder picture. I don't think it still changes my differential. I think I would still keep encephalitic meningitic etiology at the top. The spinal epidural anesthesia for the C-section, I don't have too much to say from that. My only thought is, could that be a potential source of infection? Could that be a route by which something gains access to the CNS system? Perhaps. I think valuable, pertinent information is no travel, no animal exposure, no long-term medications. So really paints the picture of a dramatic transition from a healthy individual to a very unhealthy individual at this time. So this doesn't change my differential too much. I think, if anything, it provides reassurance that I think we're on the right track, that this is a neurological, like Rabih mentioned, subacute progressive basal ganglia disorder that we ultimately will benefit imaging from to help categorize. Um, what thoughts do you have, Rabih?
Oh my gosh, I'm sweating just like you are. Um, Yeah, no, I mean, imagine this, Dan. Imagine this patient is before you right now. I think, you and I are very lucky. We practice in high resource settings where there's probably going to be like 20 people thinking about this patient from the get-go. And I think the fact that it's just you and me, and then the fact that we know that Eugene has the answer on aliquot number blank is terrible, is terrifying. It's intriguing though, when you have a history, I think mental health disorders, especially those, especially something on the spectrum of bipolar disorder or psychoses, are fundamentally basal ganglia diseases. We just don't know why they happen. We cannot see them. And the only way we confirm that they are truly idiopathic subradiologic is the time course. Just like we know a migraine is a migraine only if the patient has it for 20 years without suffering consequences, we know bipolar disorder is bipolar disorder and not antibody-mediated basal ganglia issue because it lasts for decades. And I'm so glad that we know this patient has had this diagnosis for 10 years, because imagine this, Dan. Imagine if we learned from Eugene that she was diagnosed with this 10 weeks ago. And then all of a sudden you'd be like, oh my gosh, is this NMDA encephalitis, right? And so it's interesting to say, okay, now I know she has vulnerability in her basal ganglia for the last 10 years. Is this somehow related to it? I think the probability of a relationship drops. when the patient has such a long-standing location there. But is it a coincidence that she has vulnerability in her basal ganglia and she's coming in like this today? And I'm in a tricky situation where a thought crossed my mind, but I don't want to share that thought because I think it's inauthentic to have it as a leading thought. But the reason I will ultimately share it is because it changes our empiric management. And so I'll just plant the seed, Dan, that I think this is a diagnosis all the way at the end of an MRI LP journey. But the reason we have to think about it early is because empiric treatment for it is life-saving, and that's malignant catatonia. So if you think of a patient who just underwent the stress of pregnancy, who is vulnerable to postpartum depression or worse psychosis or worse catatonia or worse malignant catatonia, you want to have that benzodiazepine in your back pocket at hour 1, 2, or 3. So let's put that thought there, but putting that thought there carries a risk of us overemphasizing what is a diagnosis that should happen after we exclude rabies, for example. But in our back pockets, we should be thinking about antibiotics for meningitis, steroids for meningitis, a workup. But gosh, do we have to think about controlling what is a ravaging, really serious condition with benzodiazepine? So that's the thought that crossed my mind. But let's keep it further down for now because I think it's too soon to deploy it. All right, Eugene, mic to you, my friend.
Okay, so Alicot 4, the vitals on admission at our facility was the temperature was 40.1 degrees Celsius, heart rate was 130 beats per minute, and the blood pressure this time was 160. The respiratory rate was 26, and the saturation SpO2 was 96% on room air. We did a finger stick glucose immediately, and it was 153 milligrams per deciliters. On neurologic exams, she appeared stiff, and her lower limbs were positioned in a frog leg posture. She was disoriented and unable to follow commands, and the GCS was 1315. Her pupils were equal and reactive to light. She had normal facial symmetry. The neck was supple. There was negative Brzezinski and Koenig signs. The muscle bulk was normal. She had a lead pipe rigidity on muscle movement. We couldn't assess the power, but deep tendon reflexes were absent on assessment due to rigidity, and the plantar reflex was normal. On the skin, there were no rashes or bruising, but she was warm and diaphoretic. Cardiovascular exams, there were normal heart sounds with no murmurs. Respiratory exams, air entry was normal bilaterally, and there were normal lung sounds. With the abdominal exams, it was soft, non-distended. There was mild tenderness over the cesarean section sites, but no evidence of infection, and there were no palpable masses. I will stop here for the discussion to continue.
Hey Dan, what do you think about like a 4-minute breakout room so you can powwow with some very brilliant minds in the group? How about that? Cool.
That sounds great.
Yeah, collect your thoughts. I think this exam is really, really powerful. So folks, we'll just come back in 3 or 4 minutes. Feel free to join a breakout room and nerd out. All right, welcome back, everybody. So Dan, where are you at? What thoughts?
So yeah, so I mean, I credit goes to my team. I mean, we had a really great discussion, and I want to shout out my teammates for everything that I'm about to say. So one of the things that obviously stands out is the degree of this patient's fever. So 40.1 automatically raises the thought of, is there a component of a hyperthermic picture? And so, one of the things that we discussed, and I think this was actually brought up in the chat as well, but whenever you hear like classic lead pipe rigidity, especially in the context of potentially psychiatric medications, always just want to make sure you're thinking about a neuroleptic malignant syndrome. All the other things that are differential in that same hyperthermic toxidrome bucket, at least for me, is also malignant hyperthermia, which can also present with that rigidity. Something else that we also talked about in a separate category, which honestly I didn't think much of, was the fact that the patient is postpartum, has had seizures, has an elevated blood pressure, has signs of stiffness, and I'm sure we'll get to like hemolysis, platelet, all those labs later on, but also considering diagnoses of eclampsia and just evaluating postpartum emergencies, I think perhaps that's another thing where, kind of like malignant catatonia, it's something that we should think about because it can be addressed with immediate therapy. And so that's kind of my approach. To be transparent, for me, I think I would still favor an encephalitic process first, but these things are hot on the differential as well. So that's my thoughts. Robbie, would love to hear your feedback, your thoughts.
I think your analysis is spot on, and I think you started off with the fever, temperature elevation, and you're making the case that it might be hyperthermia, and I agree with you. I think we've found the source of the fever, and that might be counterintuitive. Be like, wait, how do you know where the fever is coming from? Well, the fever can be coming from an elevation in the hypothalamic set point, for sure, but when you have tonic activation of your muscles generating so much extra energy, there is no way that you can dissipate that effectively. So when you see the combination of a fever this high with diffuse muscle rigidity, you should immediately come to the conclusion that the source of the fever is unrestricted, continuous hypermetabolic activity from the muscles. So for me, the fever actually collapses and is readily explained by those things. And the things that would further support that is if the fever remains a flat line and doesn't oscillate, because a temperature, if from a hypothalamic issue, should oscillate up and down. And the other clue will be that if the patient doesn't respond to antipyretics that set the hypothalamic zone, like Tylenol or acetaminophen or an NSAID. So I agree with you. I think the case for hyperthermia is super, super strong because you literally can localize the fever to the fact that she can't relax. And so I think the problem that we're trying to solve, Dan, is the patient has severe, unrestricted, unlimited muscle activity. And the question is why? And Franco, a few months ago, Franco's here actually, a few months ago, shared a case of a diagnosis of stiff person syndrome, where because of an antibody-mediated disease, the patient's muscles were super, super stiff. And that, I think, is probably best captured as a spontaneous muscle rigidity with no exogenous trigger. I think when we see a case like this, we really have to ask ourselves, before we think about things inside the body, like stiff person syndrome or malignant catatonia, we have to ask ourselves, is there an exogenous trigger for severe muscle activity? And meds are really key here. Looking for medications that have serotonergic properties causing serotonin syndrome, or meds that have dopaminergic properties or dopaminergic blocking properties that cause neuroleptic malignant syndrome, and many others, including baclofen, so on and so forth. So meds, there's some toxins that do it too, and then infection. And so the classic infection that does this, or does a version of this, is tetanus. Though tetanus doesn't usually cause somebody to be febrile and encephalopathic, but you can definitely have an encephalopathy from hypercarbia from your diaphragm not working. So tetanus and rabies are the two most important infections that do this. So I'm right there with you, Dan. I think that this is a severe rigidity syndrome, an unlimited, unrestricted rigidity syndrome causing a super high fever. And I think the question is, before we invoke endogenous diseases like malignant catatonia or stiff person syndrome, we have to control an exogenous trigger. Meds are really key. I would review them 3-4 times over. And then I think, yeah, the infections that you outlined, especially rabies and especially tetanus, are key. So what I would be doing in this person is looking at her skin exam very, very closely for any puncture marks that may suggest an unrecognized animal exposure or unrecognized focus of tetanus toxin entering her skin. So a good skin exam is key. But I think the question, Dan, is for us is, how do you think you would be approaching empiric treatment for this patient? Like, you're here in the ER, you're going to have imaging and labs in the next couple of hours, probably. What empiric treatment would you deploy to try to have this person be in a more stable state?
Yeah, that's a great question. So, right off the top, most threatening etiologies, I want to make sure I'm not missing any bacterial, obviously a bacterial meningitic picture. And namely, I need CNS coverage. So right off the top, the way that I approach antimicrobials is Do they have MRSA risk factors? Do they have pseudomonal risk factors? That helps me target my bacterial coverage. Regarding my viral coverage, do they meet criteria for HSV coverage? And then lower on the list, and I rarely get to this in my first pass, but do they meet antifungal coverage? And then finally, as my fourth and final piece is, what about steroids? Given the CNS involvement. So I guess here's how I would break it down. Does this patient have pseudomonal risk factors? I would say no. It doesn't look like she has any prior healthcare exposures, no previous exposure to medications. Does she have any MRSA risk factors? I also don't think so, but she does have yeah, I think I would say no. But if I saw this patient in the ED, I think what I would do is I would start them on Vanc and ceftriaxone 2 grams Q12 for CNS coverage. I would also, given the severity of her infection, I would obviously run this by ID, but I think I would be pretty, it would be a lower threshold for me to consider acyclovir as well in case there is a viral component. And of course, the labs, the MRI and the eventual LP, which we will get, will be very helpful for this. I would hold off on any fungal coverage right now. And then finally, regarding the role of steroids, I will be very honest. I would talk to neurology before I pull that trigger. I'm always hesitant when I give steroids for CNS empirically. But of course, if this is a true, like a strep pneumobacterial meningitis, we know that there's evidence for it. And so I don't want to be ginger with it either. I guess the real question is how high is my suspicion for a bacterial meningitic process? And I think for me, it's a little lower. So my personal bias, I think I would hold off on the steroids right now, but I would talk to a specialist and get their thoughts before proceeding.
I
What do
love
you
it.
think?
I love it. No, I agree with you. I think that, you know, I don't think we're parsimony is important here. I think of casting a very broad net, Vanc, ceftriaxone, add on the acyclovir, and yeah, I think the steroids can be very, very tricky. So talking them through with somebody's probably wise. The question for you to think about is, how are you going to get her to be looser and less febrile? You
Okay.
think antibiotics will do that?
And so, I actually think, and I think this goes back to your earlier point, I think the etiology of her fevers is actually the muscle rigidity.
Yep.
So I
Yep.
think to actually control the fevers, I need
Yep.
to relax her muscles more.
Yep.
And so I need an agent, not an antimicrobial, but something that will
Yeah.
like like a benzodiazepine, for example,
Yeah.
or some kind of a muscle relaxant that can actually,
100%.
yeah, yeah.
100%. Yeah, no matter what she has, situation is just like sepsis, where
Mhm.
no matter what organism she has, you have to treat the consequence. And even if this is rabies or tetanus, you have to treat the fact that her muscles are so stiff that if you don't relax them, she's going to die, no matter what. And so this is a patient where you get every single benzodiazepine in the hospital and you give it to her. Otherwise, she will continue to have consequences of hyperthermia, which will include DIC eventually. So I think giving her benzodiazepines and potentially giving her dantrolene is going to be very, very key, no matter what the cause. So Eugene, what did you all do next?
Yeah, so I'll continue with the labs. So we were just on the same thought processes. We were having multiple differentials at this point, infections, a generalized muscle condition. And so we went on to take some samples, but we began some cooling measures at this point. We gave some IV fluids, and we did give dantrolene at this point, and also lorazepam. So the HB was 8.1 grams per deciliters. HCT was 24.2. The MCV was 82.6. The MCH was 27.6. The white cells were 9.1, but there was slight neutrophils elevated. And then platelets was 185. We had CRP, which was 102, and procalcitonin was 10.5. Electrolytes, sodium was 129, potassium was 3.6, chloride was 112, bicarb was 20, calcium was 7.12 milligrams, phosphate was 1.89. The BUN was 30 milligrams, and then creatinine was 2.1 milligrams. For the liver, AST was there was markedly elevated transaminitis. AST was 660, ALT was 200, ALP was 42, GGT was 42.7, the total protein was 47.2, albumin was 22.1, and the T-bill was 8.3, with direct as 3.6 and indirect as 4.7. We also obtained CK for concerns of the muscle stiffness, and we had CK at 9,000, sorry. Urinalysis and microscopy, the color was brown. There was negative leukocyte esterase, negative nitrites. Blood was positive. On the microscopy, RBCs were 0 to 2. And so we're thinking myoglobinuria at this point. We also obtained a head CT, which the report came with mild cerebral edema, but no structural changes or lesions. We did a lumbar puncture, which had a normal opening pressure. The CSF analysis, there was normal white cell count. Protein was 30 milligrams. Glucose was 65. We didn't culture any organisms in the CSF. We also did an ECG on account of the tachycardia we got at first. So it was normal sinus rhythm. P waves were present. Normal intervals. The ECG was basically normal. And I'll stop here to listen to our thoughts.
I mean, I'll just jump in and ask one clarifying question. Eugene, was the bilirubin normal in your units or elevated?
Yes, the bilirubin was normal.
Normal. Okay. So, Jan, just to help summarize for everybody, the patient has a normocytic anemia, a mild hyponatremia, a elevated procalcitonin, a AST to ALT ratio of 3 to 1, and a very high CPK, and a normal lumbar puncture. Is that right, Eugene? Any other abnormalities that I missed?
Yeah, calcium was also a slightly low at 7.12.
I see.
Sodium was also 129, which was low.
Oh, wonderful. Awesome. So, Dan, what are you doing with this information? How did it help you?
Yeah, well, I will be honest, I was really hoping to see more of a more of a slam dunk picture either leaning one way. But I will say there are some things that I'm seeing here that I think fit with the picture we've gotten so far. So number one, a significant elevation in AST over ALT. I think that fits with the degree of muscle activation that we're seeing and how tight the patient is. In addition, we're seeing the direct, or I guess it's indirect predominant. That's the CK being elevated, of course, fits with that muscle tightness. Things that I am a little surprised by is the LP. The LP is, from what I'm hearing, it looks great. There's no white count elevation. There's no elevated protein. It looked clear. And so, I think my initial reflex to this is how much does that change my, I guess now my post-test probability? I still think I would favor a meningitic and syphilitic process. I think there are still some signs that suggest that there is that going on. I mean, we see, of course, the hyponatremia, but we can see that with any kind of infectious process or any kind of inflammatory process, and with the CNS edema, with the cerebral edema. I think I think we mentioned the bicarb was a little low. That could also be explained by in the setting of the seizures and a potential mild buildup of lactic acidosis. So to summarize all this to say, this objective data is very helpful, but I don't think it shifts my differential too much. I think it points to the fact that the patient has diffuse muscle rigidity that is resulting in multiple lab abnormalities. There isn't a slam dunk infectious picture that I would have thought, but I still am favoring that as my leading differential. Of course, followed closely by a NMS versus serotonin syndrome type picture. Yes. Robbie, what do you think?
I'm right there with you. I think that we have to be careful eliminating an encephalitis based on a meningeal analysis. And I think that, ultimately the lumbar puncture is analyzing the meninges. And I think especially with viral organisms, you'd have to be careful. So I don't think a normal LP exonerates the hypotheses of the infections we'd primarily be worried about, which is tetanus and rabies. And I think based on the fact that their patient doesn't have animal exposure, I think rabies would be less likely. And so the question is, does she have tetanus? And remembering that she just had surgery 2 weeks prior to this is going to be really, really key to hold on to your mind. So I'm right there with you. I think we've gotten confirmation that we weren't wrong about the muscles and the significance of them. And I guess the question that you and I have to figure out, Dan, is how do we get clarity on this? Like what do we have in our toolbox to be able to push the case forward? Because as you said, we haven't had a profound clue except just reinforcing the notion of the muscles being really, really important. So what do you think?
Yeah. Okay. So I think our main goal now is to try to, like you said, try to isolate the etiology of all of this.
Mm,
My reflex thought is, of course, we got a head CT. That's great. I think getting an MRI would be another great next step. I
mhm,
haven't heard anything about cultures yet. My suspicion is lower, but I think it might be good just to get those cooking. Of course, we'll get blood, but also I think a CSF, paraneoplastic a panel would be helpful, a PCR broad panel, just to exclude all viral etiologies. I'm sure there's my suspicion for this is low, but I'm sure we have a UDS cooking just to make sure we're not missing any medications that could have been at play here. Um, and we've already given the dantrolene for the potential hyperthermic toxidrome. Those are my reflex thoughts. I'm
yeah.
sure the EE. I can't remember if we got an EEG. Um, I know we mentioned the EKG.
Mhm.
That would also just be something I'm thinking about in case there's a concern for a subclinical seizure that's kind of driving all this in the background. Um, yeah, that's kind of my gut initial thoughts.
That's outstanding. Truly. I'm right there with you. And if I have the luxury of trying to simplify it, I think we're on the hunt for a specific microscopic molecule.
Mhm.
And the question is, are we looking for a small piece of tetanus toxin? Are we looking for a medication that was administered that triggered NMS? Or ultimately, if we don't find either an exogenous infection like tetanotoxin or an exogenous substance like a medication, wondering if this patient has an antibody causing a paraneoplastic process is the arc that we're going to have to take in terms of diagnostics, right? Find a med, find a toxin, find an antibody. At some point, we're going to have to cross the threshold if we don't find anything and the patient's getting worse, empirically treating her for an antibody with aggressive immunosuppression. And you'll see that's the journey that these cases take is. But if at the same time we support her empirically with calming her muscles down and she improves significantly, then we'll be able to say, wait, maybe this wasn't something outside her body. Maybe this was mental health disorder plus post-pregnancy psychosis, adding to catatonia and malignant catatonia. So I think what tools do we have? A really good skin exam, especially her wound for tetanus toxin, a really good med rec, empiric antibacterial treatment, even though the probability is very low, and then watching her clinical course. She turns the corner and you don't find a med, you don't find tetanus toxin, you don't find an antibody, then malignant catatonia. But if she doesn't turn the corner, the question will be, do we broaden to immunosuppress her because she has an antibody, just like Franco's case? So Eugene, what did you all do next?
Yeah, so we'll move to Aliquot 5. So at this point, we're also having multiple differentials, and we have still not pinned down the exact cause of this patient's symptoms. And so we consulted neuro and psychiatry. We have taken samples for blood cultures, but I've not reviewed it yet because I want us to follow how we also had the case presented to us. So we're waiting for the cultures to come later. And Neuro came in and did further history because I saw in the chat and that was clear that there were concerns about whether we had to probe more in the history. And what Neuro and psychiatry did was that they went further to take the contact of the peripheral side, as a rural clinic, and then ask more questions. It revealed that 10 years ago, the symptoms the patient had, which was pointing to a mental health disorder, were of manic symptoms. And she actually took antipsychotics, which she stopped when she felt better. And we also made contact to the peripheral clinic in terms of the medications. And we realized that within the first 24 hours, they were suspicious of postpartum psychosis based on the bizarre symptoms that she presented with the aggression and then the initial paranoia and also refusal of food. So they gave IM chlorpromazine 50 milligrams. And so this is where I will stop for us to further discuss.
That's great. Oh, that's great. Ken, I may have missed it. What was they gave a medication? I assume it was an antipsychotic. Did you say, honestly, that's all I need to know.
It was an antipsychotic, yeah.
Okay. Yeah, honestly, that's all. I'm pretty sure it was a first gen. Regardless.
First,
Okay.
correct.
Okay, got it. So that is super helpful. And I would say the reason it's helpful is now I think that picture really ties into why I think the patient has this rigidity, this diaphoresis, this stiffness. Now I think my differential switches a little bit, and now I think I'm going to place the like we talked about, the hyperthalamic toxidrome NMS, malignant hyperthermia bucket, higher on my differential because I have a potential trigger, which is this medication. And so now my biggest thought is that the leading etiology of all of this? And so if that is the case, what is our next step from there? And I think the fact that the patient has already gotten the dantrolene is helpful. One of my favorite schemas when I approach hyperthermic toxidrome, I hope it's okay if I shout this out. There is an ICU one pager called hyperthermic toxidromes that kind of breaks down the 5 different subtypes. And so I think this patient definitely falls within the neuroleptic malignant bucket, but also, thinking about malignant hyperthermia. And we know that given that the patient has a recent antipsychotic use, it further supports that. I'm interested to know clinically how the patient fared after the dantrolene. If that had any impact, I think that would also be further fuel to support my diagnostic change. But this was huge. So great. Shout out to your team for consulting them, and shout out to the teams for figuring this out. Robbie, what are your thoughts? What are you thinking?
Yeah, I think, Eugene, this is a outstanding diagnostic journey, which I know is not complete yet, but I think the power of your detailed physical exam helps really make a lot of progress in retrospect. And when you walk in and you see a fever of 40 and you see the patient's confused, meningoencephalitis becomes your leading thought. But when you see how stiff all her four limbs are, you just acknowledge the reality that most people who have meningoencephalitis are completely flaccid, obtunded, and don't move, let alone are moving so much they can't move. And that's what's happening with her. She is moving so much that she can't move, meaning that she is contracting every single muscle, opposing and I forget what they are, the term for opposing and non-opposing muscles. And so that your syndrome then becomes why are her muscles moving so much. And by far and away, meds are the trigger. And so scrutinizing that as you all did was absolutely outstanding. And I think it just reinforces the notion of the seed that I think we have to plant in a patient like this, which is when we think fever, we think antibiotics are life-saving. But I hope this case reinforces to you all that in a case of fever, 0.01% of the time, benzodiazepines are life-saving and dantrolene is life-saving. And you have to give it the moment you suspect it because every delay, I guarantee you, it's probably not been proven in trials, but a delay will only cause things to worsen. So remember, benzos in very, very rare situations can be very, very life-saving. And I think they were probably given to this patient very quickly. And even if they don't even if they don't heal the patient, they certainly made her have a better outcome than whatever she would have had if we had been too fixated on infection for too long. So yeah, I have nothing to add except to emphasize that the anemia here may be relevant, Dan, because for some reason iron deficiency hasn't yet to be clarified role in neuroleptic malignant syndrome. And when looked for, a large number of patients who get NMS are iron deficient, and people don't really understand why, but that might be an elegant hypothesis to link in even more vulnerability to this disease. But yeah, Eugene, I'll hand the mic to you to tell us what happened and how the case ended.
Yeah, so just like you were presenting the thoughts, that's how we started thinking that this could be an NMS So we went on to give bromocriptine, and also we did electroconvulsive therapy. And at this point, the blood cultures actually came. We isolated coagulase negative staphylococcus. We also did an endocervical swab and high vaginal swab, but we found no organisms, no E cells, no Q cells. We didn't find T vaginalis as well. And the patient started getting better on the ECT after 2 sessions, but then her GCS declined further to 11 out of 15, and she began desaturating. So she was transferred to the ICU and then intubated. We did her ABGs, which had a metabolic acidosis picture. pH was 7.26, and the PCO2 was 32, HCO3 was 18, lactate was 4.6. And then we also repeated her BUN pregnant after the fluids were given. Urea had dropped to 31.32. Pregnant became 0.76. And also sodium improved slightly to 140. Potassium was 4.16. Calcium was still around the same area at 7.16. And then bicarb was 23. And we later did liver function test, and the transaminitis was improving. So the patient at a point remained unable to wean off ventilatory support for a few days until we did a third ECT, and then she started getting better. And I would reveal the final diagnosis, I mean, which we have an idea of, but I'll reveal it in the last article. Yeah.
Got it. Okay, yeah. So just to summarize, so the patient underwent the bromocriptine dantrolene therapy. GCS progressed down to 11, or it declined down to 11. Transferred to the ICU, got intubated. While in the ICU, the patient had some improvement in lab abnormalities, improvement in the AST, ALT, improvement in their function. And then, if I understand, that's kind of where we're at right now. Is that right?
Yeah, you're correct.
Okay, got it. So, I think that sequence, I think, fits with the fact that the therapy that we gave is what actually helped turn the patient around. So I think, honestly, what you're describing to me fits with exactly what our differentials, like an NMS picture that was driven in the setting of this antipsychotic use that we have now, that your team corrected with the dantrolene and the bromocriptine. So I think, if anything, this is consistent with what we thought. Honestly, sometimes the GCS drop doesn't always surprise me, because we just gave the patient dantrolene, bromocriptine, which of course can have, I think, effects on airway protection. But I think the overall uptrending course is, I think, favoring that this is our likely diagnosis. Yeah, Robbie, what do you think?
Yeah, I think well, one, I know you're I know this is round number 2 or 3 for you, and I think you're the way you're articulating yourself is so advanced, full of nuances and full of authenticity. And I'm struggling with this case, to be honest with you, to give you a precise diagnosis like you are. And I'll just take a moment to sort of outline my tension as well, which is, I think the bedrock of this person's disease course is her mental health disorder. And I think we're seeing two potential relationships to the current syndrome. The first is, I think, a very a more familiar entity to all of us, which is neuroleptic malignant syndrome, where somebody with often a controlled psychiatric illness gets a dopamine antagonist and develops a rigidity syndrome just like this. The other way that you can find yourself here is taking care of a patient with an uncontrolled psychiatric syndrome who progresses through catatonia as part of that psychiatric illness, and then has a very malignant version of that catatonia. And so distinguishing, ultimately, I think the question before us is this drug-induced disease, neuroleptic malignant syndrome, or is the drug an innocent bystander and the drug was not enough to control her progression of her mental health issue? And I think distinguishing those two things is very difficult. But if you just go back to what you clarified so early on, the sequence of events, which is she had behavioral changes and selective mutism before she got this sick. And ultimately, what's the best way to distinguish between malignant catatonia and NMS is the time course and the sequence of events. NMS should begin in a patient who's fairly well controlled, who gets a drug, who gets worse. Malignant catatonia proceeds through a phase of of a loss of control of the psychiatric illness. So for me, I'm wondering if she has malignant catatonia over NMS because she was not getting treatment. She's spiraling into a range of a risky psychiatric under control with her behavioral symptoms. And then boom, she gets super febrile, super sick. And the fact that she needed ECT, which is the first line therapy for malignant catatonia, unlike NMS, where it's third or fourth line, has me wondering whether she in fact has malignant catatonia. Ultimately, though, it's not an acute crisis to distinguish those two. It's just a matter of what our judgment is about whether at onset was her disease under good control and she got too much med, or was her disease actually getting out of control? And in scrutinizing the history a little bit closely now in retrospect, I'm seeing a little bit more that her disease may not have been controlled and that she progressed through catatonia, behavioral changes, not moving right, and then may have gone into the malignant spectrum. Yeah, but ultimately, I think we have a lot to learn from Eugene. So I'll hand the mic to you, my friend, to tell us how you were putting this case together.
Yeah, so thank you very much. And yeah, we're on the same thoughts with you. So first off, when the patient came with fever, generalized stiffness, and then the altered mental status, usually what we are taught here is that we try to break down each symptom and then try to understand objectively if what a patient is presenting, we're actually on the same scale as the patient. So is it subjective fever or objective fever? And then we also try to understand what is the patient meaning by generalized muscle stiffness? Is it actual motion stiffness? Where is it velocity dependent or non-velocity dependent? Or is it just muscle cramps? And then we also try to see the level of mental status. And then from that point, we try to also look at each symptom and then look at which organ system can actually present with that particular symptom. So we're right there with you as how the thoughts were progressing. We started thinking about meningitis, which actually the peripheral side also thought about. But if you look at the presentation of the symptoms where the patients initially first had eye pain and some kind of viral symptoms, we were thinking that probably those were some form of initial viral symptoms, because when a patient took analgesics, the history said that it started getting better. Then afterwards, we started thinking that maybe the cascade of symptoms was actually psychosis, that's postpartum psychosis, because she was within the period where you literally diagnose postpartum psychosis with agitation, aggression, paranoia. So we're thinking initially the hydrophobia was also raising thoughts of rabies to us. But we also thought that could it actually be paranoia? That's because the patient actually started by drinking excessively, which usually doesn't present with rabies, because rabies will actually do some form of laryngospasm. So the patient started drinking excessively and then started refusing the water. So psychiatry thought that could be some level of paranoia. And so when they probed further, they realized that the previous symptoms that she had 10 years ago, and just as Rabih, you said, actually was not fully taken care of. So when the patient was actually weaned off the medications, she was actually primed. So when she received that antipsychotic, that actually tipped her off into having a neuroleptic malignant syndrome. So we finally made a diagnosis of neuroleptic malignant syndrome triggered by the chlorpromazine in a postpartum woman with underlying bipolar affective disorder. And actually, to clarify, when we did the bromocriptine, it was not really a form of improvement with the patient. It was actually after the ECT that we started seeing improvements with the patient. It's on a third ECT, we're able to wean off ventilatory support, and she's currently doing better on the wards. So that is what I have to say on this case. Thank you.
I just want to thank you, Eugene. This was so cool, so educational. I think the amount of work that you probably had to do to take care of this patient and then put the case together is nothing short of monumental. And I think you taught us a lot today. So thank you so much. Really appreciate it. Yeah, Dan, what are you thinking?
Wow, I'm not even sure what I'm thinking. That was just such an incredible job. Like, yeah, Eugene, you killed it, man. I mean, I started off thinking, oh, this is infectious. And then we got more and more of the history. You give us a little tease with the history of the mental health disorder, and then it all kind of comes together as we learn more about the patient's previous history 10 years ago. I think honestly, my main takeaway from general practice is how important the history is and how important it is to maintain a very broad differential. And I think the fact that I think we were able to refocus and say, hey, wait a second, our must not miss things. Yes, encephalitis is on there, but also NMS, malignant catatonia, and having a lower threshold to empirically treat those things. I think that's also critical. Something also that I think I will take away, which Eugene, your team did amazingly, is I didn't see anything about giving antibiotics, waiting a few days to see how the patient responds, and then saying, oh, okay, now we failed that. Let's try these other things. You guys were like, hey, here's our options. Let's hit them all. Let's see what fits. And I think that is so helpful for me to remember as, you don't, for the patient in front of you, they need a solution. And so being aggressive with options as opposed to approaching things piecemeal, especially in this case, I mean, it paid off big time. So, man, shout out to all of you. Yeah, that's my thoughts.
Your thoughts have been so precise and so articulate and so spot on from the beginning to the end, my friend. It was a real treat to discuss this case with you, and I'm glad we were a tag team in this one. It's a very difficult case to digest, and so it was an honor. Thank you again, Eugene, and big shout out to Noreen and the mysterious person who was helping you scribe as well. Unfortunately, I have to head out to make it to work on time, so I've made Zachariah the host, and we'll enjoy digesting your teaching points later, Zachariah. Thank you all so much.
Gosh, where do I start? What a case. Thank you so much, Eugene. I think let's start with something that Dan brought up right at the start was that our postpartum period is fraught with complications, and it's not something that we often get in a good approach to. But you can sort of start from the head and go down. So due to the hypercoagulability that can happen postpartum with immobility, patients are at risk of a cerebral venous sinus thrombosis. When you come to their lungs, for the same reasons, they can get a pulmonary embolism. Then you go to the heart, and you have to remember that preeclampsia and eclampsia can sometimes occur postpartum, especially in the first 48 hours, as sort of the first manifestations of the disease. And in addition to that, patients are at risk of peripartum cardiomyopathy. Then we go to bleeding, and there's a reason obstetricians take postpartum hemorrhage so seriously is that if you've ever seen it, patients can go into shock and bleed to death literally within minutes. So it can be quite frightening. We then move on to the infectious risks, and while the most common ones are endometritis, there are other ones that are more rare but potentially more deadly. That includes tetanus, as Rabih reminded us, as well as C. diff colitis in patients who are on antibiotics before they gave birth. Lastly, they can get vulval infections that can represent invasive group A strep. Rabih then reminded us that sometimes when a patient has a systemic disease, it can sometimes be truly systemic, like a viral illness, or there's a small area of focality with widespread dissemination, like ascending cholangitis. We then moved on to the extremely unique symptom of hydrophobia, which your first, second, and third pass should always be rabies. But if you rule that out, you can consider somebody having a hyperactive gag reflex, or in some situations, they can be psychotic. We then discuss basal ganglia diseases, and the classic combination is both a movement disorder and a behavioral issue, and it usually presents with abnormal movements that can be difficult to describe in somebody who has psychiatric issues, as well as the absence of any sensory or motor weakness. Lastly, well, not lastly actually, because it was so much, but we discussed temperature, and it's something I actually didn't fully understand until recently. So I think a simple way to describe it is that fever is your body intentionally rising your temperature, with the hypothalamus raising that centroid to make your body warmer, usually seen in patients with infections. It responds to analgesics like acetaminophen, and usually does not require specific treatment. In contrast, hypothermia has nothing to do with your hypothalamus, and it's an unintentional temperature rise due to a metabolic or metabolic disorder. Usually this is caused by heat overproduction, with your body losing the ability to get rid of heat, and it's seen in diseases like heat stroke, malignant hypothermia, sympathetic and anticholinergic toxicity, and in this case, neuroleptic malignant syndrome. Usually it's associated with rigidity, will not respond to your common antipyretics, and can lead to DIC, rhabdomyolysis, and death, and hence why it needs emergent treatment with cooling and benzodiazepines. Lastly, we discussed like a quick illness clip on a disease I'd never heard about before, which was malignant catatonia. Usually catatonia is defined as a disorder of both motor and behavioral issues, and the patient's unable to move despite having physical ability to do it. But the malignant form presents with severe autonomic instability as well, and requires emergent treatment similarly to NMS with ECT, electroconvulsive therapy, and benzodiazepines. Lastly, as often is the case, the history is our final diagnostic test. And when you don't know what's happening, why a patient progressively is getting worse and sicker, with so many things going on, often there might be just something that can be missed. And if you go back to the history, you'll get your answer. Thank you so much for the incredible case. I'll be thinking about it for a while. Have a good day, everyone. Bye.
Great job, guys. That was incredible. All right, I think that's it. We'll see you all soon. Bye.